And the first thing I'd like to say about anxiety disorders in older people is that the research shows that anxiety per se decreases as people get older. So there's very little literature on anxiety disorders specifically in older people. So if you see anxiety with a new onset in a geriatric patient, it's not an anxiety disorder the way we specifically or traditionally think of it. People can still obviously experience anxiety, but it won't be one of the many disorders that I'll try to cover today. But just like a show of hands, I mean, you guys have different levels of knowledge. I guess we'll go as we go along. Maybe you can just pop up and ask questions. I'm going to stick to the DSM-5 for today, just to have a sort of a place to hang my hat on. And in DSM-5, anxiety disorders are grouped together, both developmentally, so they go in order from young to older, but almost all the anxiety disorders have their onset in childhood, early adolescence, or early adulthood. Again, you don't really see it for the first time in someone over the age of 30. And if you do see it, then you have to think about medical issues. You have to think about mass depression. You have to think about maybe just a short-term anxiety response to a stressful life events, but not anxiety the way disorders the way we traditionally think of it. They're grouped together because anxiety is obviously the predominant symptom, and there's some functional impairment. It interferes with a person's life. And it's ego-dystonic. For those of you who are not familiar with this term, ego-syntonic means it's okay. Like, some of our politicians, their behavior is really ego and syntonic, even though afterwards they may apologize when they're caught. It's ego-syntonic. They don't think there's anything wrong with what they do. Ego-dystonic is somebody feels anxiety and is troubled by it. And one of the nice things about all the anxiety disorders, especially with, like I said before, younger people, early adulthood, and people who are untreated and present for the first time later in life, they all respond to specific psychotherapeutic or psychological treatment, and they all tend to get better. I mean, not everyone, but most of them tend to get better. So these are just some of the disorders in DSM-5. Separation anxiety disorder, obviously in children, just the way it sounds. These are kids who have a hard time leaving their mom. Selective mutism, which actually we now know that someone with a history of selective mutism, it's actually a pretty serious disorder, and later on in life they go on to have other disorders. So the mutism may go away as they get older, but they'll often have depression, anxiety, and a host of other symptoms. Specific phobias are very, very common. 40%, depending on the survey, 40% of the population will admit to having one specific phobia. In medical settings, the only one that's really usually of significance is people who have blood illness phobia, the ones who are afraid or to give blood, take injections, self-test for diabetes. That can be quite serious if somebody has that disorder. And it's often influenced, of course, by people having a vasovagal response. They actually pass out if they see blood or have blood taken from them. Social anxiety disorder, just the way it sounds. Panic disorder, which is actually probably of all the disorders, the most important, I think, clinically. We'll go into that in more detail. And agoraphobia in DSM 3R, and 4, you really had to have panic disorder, and then you kind of coded it on agoraphobia or with or without agoraphobia. In DSM-5, they said you can have people who just are agoraphobic, being afraid to travel or leave their home on their own or unaccompanied. In most clinical settings, if you actually talk to someone with a history of this disorder and you really do a careful history, you'll usually find some onset of panic. They may have only had one panic attack or two in their life, and that made them sort of phobic. You do see, of course, a lot of agoraphobia in elderly, and we can call it agoraphobia. I'm not sure it's the right term. People who are afraid of falling, have a history of falling, being frail. I'm sort of sitting very funny because I'm trying to be in the camera and still be able to reach my slides. I look like I'm slouching. We'll talk about that a little bit and have questions. But again, I can't see all of you because I'm looking at the slideshow and I'm afraid to touch anything. and rearrange my camera, my computer, and lose everything. But feel free to ask any question. Just unmute yourself, pick up your hands, talk. Generalized anxiety disorder, those people will recognize themselves or in patients. These are worriers, the chronic worry. They worry, their brain always finds something to worry about. You know, this I sort of give, you know, to the medical students, to maybe some medical students here doing an elective in geriatrics, so maybe this rings a bell. Victoria? No? Anyway, anxiety itself, some background information. It's not really, as we know, pathological. It's useful in small, moderate amounts for motivation and enhanced learning. I always make a joke. Sometimes it goes over and not that if before I lecture, if I don't get really anxious a little bit, I know it's going to be kind of flat and not very useful. You want to have some anxiety, not enough to disorient yourself or make you dysfunctional, but enough to motivate you. And I guess Downstate decided to help me today by making sure the link to my computer didn't work. Fear and anxiety is hardwired, used for fight versus flight. And we actually think that in some psychopathological conditions, we postulate that anxiety is missing or attenuated. People in psychopathy, often with substance abusers, they still experience anxiety, but when they're abusing substances, when they're injecting themselves with a needle that may have been used by someone else, they're really not thinking of the consequences. They're not anxious about their drug use or their chronic alcohol use. So again, it's, you know, it's kind of on a continuum. I mean, this is in a slide from the early 1900s, 1908, which indicates, like, as you can see on the left side of the slide, low anxiety, almost to the point of sleep, waking, increasing alertness, and there's some optimal level. This is called the inverted U curve. It's been replicated many, many times, and it's one of the laws of psychology. Yerkes, you may recognize the name, is from the famous Yerkes lab, his work with apes and chimpanzees. So just some background information. We know, and I'm sure you guys all know just from your experience so far, that really only a minority of patients present with anxiety, depression in primary care for actually end up in mental health treatment. Only like a third to at most half of patients are treated. Most patients are treated in primary care settings, not in psychiatry, and the rest are in specialty. And for most Americans, primary care is the de facto mental health care provider. I really should add also prisons. Unfortunately, today are also the primary care de facto mental health provider for people with chronic, seriously mentally ill. But we're talking today about anxiety disorders. Old data from the World Health Organization, just to show that basically, you know, anxiety disorders, depending which disorders you include, actually outstrip all other disorders, including depression. But the prevalence rate in this study was like 10% for anxiety disorders. But in primary care settings, they found only about half of them were recognized. And when they looked to see if they were offered drug treatment, only about half of those got treated. So really only about a quarter, and data that's more recent shows the same pattern of results. One of the significant findings, of course, is that there are gender differences in the neurotic disorders. As we know, women get the diagnosis of depression almost 2 to 1. Similarly, when it comes to anxiety disorders, they're more likely to be diagnosed 2 to 1 in terms of men in comparison to men. OCD used to be part of the anxiety disorders, but it was taken out in DSM and given its own category, OCD and spectrum disorders. And actually, OCD, as far as I know, is the only psychiatric disorder that's evenly distributed between men and women. There are no significant differences gender-wise. I guess we can skip over this one. I mean, this is a slide that I like showing, as just, you guys know it already, that from the 1990s, more than half of the treatment for anxiety disorders was actually for non-psychiatric medical treatment. And most of that was wasted treatment. These are the patients who tend to get lots of tests, you know, over and over again. So if they're GAD or hypochondriacal spectrum type disorders. The other thing that I thought was interesting, that in 1990, look at it, 2% of the cost of health dollars went to pharmaceutical drugs. Today, and only 1/3 went for direct treatment. Today, prescription cost, as you can see, is almost half of the money that's spent on psychiatric care. And as I said before, more than twice as many men as women are treated. Their incidence is also higher, but not to that degree. What's interesting in psychiatry and psychology is medication-only treatment has increased dramatically. And when I was trained many years ago, most psychiatrists could do psychotherapy and were interested in doing psychotherapy, so combined treatment was quite common. Today, it's quite rare, as I'm sure you know. It's hard to find a psychiatrist who is either able, willing to provide psychotherapy and step care for these patients. Because one of the points I'll make is for most of the anxiety disorders, the treatments that we have, whether they're SSRIs or the newer benzos, or what would you call them, the anti-anxiety agents, are actually contraindicated, as you know, in elderly because of the risk of falling and fractures. So psychotherapy approaches are really called for, but there's a problem in terms of finding competent places to refer patients to.
Isn't there also a problem in terms of compensation, to use the term broadly?
Yes, but that's why I sort of hinted at it by saying willing and able. You have to be able and willing. So if you're a psychiatrist, you probably could double or triple your income by just doing medication management versus if you actually provided psychotherapy. It's an interesting experiment, a natural experiment. The happiest psychiatrists in the world are from where? Which country has the happiest psychiatrists?
I don't know.
Canada. And the reason is, this is an informal observation by other mental health professionals and at conferences. In Canada, they pay the psychiatrists the same, whether they do medication or psychopharmacological treatment. So most of the psychiatrists that I met from Canada are actually doing both, and they're very happy. They're really the happiest group of physicians I've ever met, are psychiatrists from Canada. The psychologists from Canada are miserable because they're not reimbursed under the National Health Service.
Oh, wow.
So if you ever want to see a PhD psychologist, you have to go outside the system. So this, how we provide care. I'm going to skip this slide and let's go straight to sort of the phenomenology. If this is overly simplistic, please forgive me. But of course, panic attacks are associated with certain symptoms. It's useful to think of like a mnemonic, cardiorespiratory symptoms, shortness of breath, palpitations, sweating, trembling and shaking. In DSM-4 and 3, the first one that they listed was shortness of breath for two reasons. One was Donald Klein, who was chair of that committee, had a whole suffocation hypotheses about shortness of breath and suffocation as leading to panic. And since he was on the committee, he made it number one. But also epidemiological in American patients who were born and raised in the United States, it actually was the number one complaint, shortness of breath. I don't know what it is now, but this is where you'll see differences in different cultures and what people complain about. Choking, chest pain and discomfort, GI type symptoms. Think of, nausea, abdominal distress, urge to defecate or urinate, neurologic symptoms, dizziness, unsteadiness, lightheaded, chills of heat, paresthesia, depersonalization. Just as an aside, the most disturbing symptom for all patients is depersonalization or derealization. When you see a patient with that, they're usually the most severe in terms of pathology. They usually have the longest illness. The analysts had the theory that depersonalization and derealization was a defense. So like if you depersonalize, you don't really feel anything. And the anxiety is so overwhelming that they sort of dissociate. And I think that old analytic theory actually holds water. One of the few analytic theories that often, a lot of theories didn't really hold up on the testing, but that does. And of course, the thoughts. What are the thoughts when people have a panic attack? usually fear of going crazy, losing control, or dying. In a study we did years ago at our anxiety disorder clinic when it was up and running, we found that 2/3 of the patients actually had 2 or more of the cognitive thoughts. So sometimes people would be afraid of dying, sometimes they'd be afraid of losing control, sometimes they'd be afraid of going crazy, sometimes they'd have all 3 thoughts depending on the situation. So that's the phenomenology. I'm sorry. To get the diagnosis, you have to have a recurrent, unexpected panic attack, right? So panic disorder is you have a panic that comes out of the blue with no known reason. Now, that means to the patient, it appears to be untriggered. If you actually get to know the patient, you may figure out the triggers, but psychologically, they may not get it. So for example, 90% of patients, as I said before, usually have their first panic attack and disorder in late adolescence, early adulthood. That's because people for the first time are actually separating, going off to school, or have expectation that they're going to go to work or move out of their home, but they may not connect that event as leading to the panic. But you either have to have, multiple attacks, or at least one attack that has led to persistent fear or concern about having more attacks. And we call that fear of fear. You have the sensations and people monitor themselves. The more they worry, the worse it gets, the worse it gets, the more they worry. And it's sort of a downward cycle. And then there's a significant change in behavior where they kind of avoid things, where they feel that they're not going to be able to get help or escape. Sometimes, as I said before, fear, even the symptom can, bring on the attack. Like in this little cartoon, the researcher is asking what triggers the panic attack, and the patient just sort of runs out the room. Sometimes you'll have patients that say, I don't want to talk about it, as when you try to go through all the symptoms. They're not being necessarily just difficult. It's almost like they don't want to talk about it because it's so unpleasant. They're afraid it'll lead to an attack. So they use a massive avoidance. The other thing you'll see with all the anxiety disorders is a great, comorbidity. Obviously, these are patients, as I said before, they overutilize primary care. As you can see, one study was a 22% prevalence among patients who were rated as overutilizers, that they had panic attacks that were either diagnosed or undiagnosed. I remember when, I'm, I guess, old enough to remember when managed care started. We were all very excited here at Downstate. We thought it would be the best thing for the anxiety disorder clinic. We'd see these patients quickly. They would stop getting all these unnecessary tests. That may work in Canada and other countries where you really have a system that makes rational sense. Like in England, they have the NICE system, NICE, where patients are identified early and referred for, actually in England, they're referred for bibliotherapy or websites, and only those patients don't respond, get a therapist. But what we found, as you know, is managed care doesn't mean managed care, it means denying care. It's actually putting hurdles in patients to make sure they don't get help. But again, patients with chest pain and negative angiograms, anywhere from 30 to 40% will have panic disorder. These patients often have comorbid irritable bowel syndrome, unexplained vertigo, migraine headaches. Chronic fatigue syndrome patients will often complain of panic attacks and undiagnosed. So there is some sort of, quote, underlying theme that may be some sort of autoimmune disorder that underlies all of these conditions. Again, some of the repeated characteristics of panic disorder is that there's repeated panic attacks. And the way to think of it is that there's an autonomic storm. People feel overwhelmed. But the other thing to really measure clinically is to ask people how long it lasts from beginning to end. It's supposed to start and end, I forget what DSM-5 says, I think within 20 minutes. Sometimes language is very interesting. Patients will use the word panic when they really mean that they're sort of chronically worried, or they may be obsessing. And if they do actually panic and have intense symptoms for hours, we're not dealing with panic attacks or panic disorder as we traditionally think about it. We're dealing with something else, whether it's an undiagnosed medical condition, whether it's dementia, an undiagnosed cognitive distortion problems that the patient's responding to. Roughly half of patients with panic disorder will develop, as I said before, the agoraphobia. There's a strong genetic factor, and actually of all the diagnosis in DSM, I think when you use a semi-structured interview and you actually stick to it, the concordance rate for diagnosing panic disorder is like perfect. It's like a 1. It's, I think, one of the only disorders where you get perfect diagnostic things. Over time, we know that these patients, if you don't treat them, they'll go on to develop a major depressive disorder, probably about half of them. It's also involved in increased substance abuse and dependence. Roughly, most studies show in that range. And there is a possible increased suicide risk. And severe anxiety is considered a suicide risk, but actually I think the pathway is usually anxiety with depression. So if you're hopeless and you're actually agitated and anxious, you have the energy to kill yourself. So these patients are usually comorbid. When people are simply panic disorders, simple GAD, not complicated with depression, they really have no increased risk for suicide at the moment, but over time they may. We know panic can be provoked in the laboratory by sodium lactate, caffeine, CO2 inhalation, isoproterenol. There are lots of substances that can provoke panic. Make people disorders worse. And people and they're slower to habituate, so they actually have some sort of issue going on. As I said before, good response to cognitive CBT, as well as psychopharmacological treatments. So here I'm going to slow down and take some questions, because the first line is the SSRIs, right? And basically, which one you use, the evidence base says they're all more or less equal. So what you should be doing is, if a patient has had it before in the past, always ask them what they responded to and give them that. Or if they know family members who have similar symptoms, and if they're responding to an SSRI, give them the same SSRI that the family member has. That's sort of poor man's, genomic medicine. We don't have to test, we could just go by that. But the other thing is that most of these patients, if you give them a full dose, for example, if you're going to treat them with Prozac, and you gave them a full dose, a 20 milligram dose, 90% of them will discontinue the medication. They can't tolerate it. I'm not telling you anything you don't know. Questions, comments, concerns?
There are no questions in the chat, but dear all, please feel free to unmute yourself and speak up, or post them in the chat.
Right.
What are the reasons for discontinuing the medication?
Okay, so this is a really good point. I'm glad you brought it up. The research shows, that when you discontinue an SSRI in a younger person, the relapse rate is roughly 50%. The relapse rate for someone over 50 is much higher, and the general clinical rule would be with somebody who's doing well on an SSRI, you tell them to stay on it. Not forever. Clinically, people don't like to hear the word forever. You say to them, you're doing really well, there's no reason to come off of it. They should be on it, quote, for life.
But why don't they?
Because stigma. I mean, sometimes it's the side effects. Obviously, if people are having side effects and have trouble tolerating it, you should always try a different medication that may not have that side effect for them. So you could try a different SSRI, or, one of the SSNRIs. But mostly, I think people always think that it means I'm crazy.
So what percentage don't adhere to their therapy?
I don't think it's that. I'm smiling because I don't know if you can see my smile on the camera, but most don't adhere to any therapy, whether psychiatric, medication. What are the quote non-adherent rates? Well over 50%. So it's always interesting to me, and I'm sure by now at this point in your career, hopefully people have talked to you and you've learned, keep it simple. SSRIs, one of the benefits are that you could, it's a single dose. doesn't make a difference whether you give it at night, during the day, or in the morning. Obviously, if patients find that it makes them a little sleepy, you give it to them at night. And then I ask people, you know, how are you going to remember to take it? I mean, my mom, God bless her, takes 0 pills. I take 3. So how do I remember? I couldn't in the beginning, but I also, I'm the generation that if I don't wear my watch in the morning, I feel that I'm naked. So I keep my when I take off my watch, I put it near my medication or put my medication directly on my watch. So I remember in the morning. So I think, especially with someone who's older and is already, you know, having cognitive issues, I think you have to go through those steps with them or their caretakers or providers. Yes. But people don't want to be on medicine because they think that they're crazy. And I think that's true across all cultures. I think the only difference is some cultures have a much stronger stigma than others. But everyone, except maybe if you're in the Upper West Side, you know, single, and then you talk openly about seeing your shrink, and maybe you talk openly about your medication that you're on. But even then, people don't talk about medication. They may talk about the shrink, but they don't talk about medication generally. Does that answer your question?
Yeah.
Dr. Friedman, there is another question in the chat, and the question is, are there any other types of therapy besides medications and cognitive therapy that are effective for panic disorder?
Interpersonal psychotherapy is the other one that has an evidence base, which is a form of psychotherapy. Medications, SSRIs are the first line, as we know, but tricyclics work. MAO inhibitors probably work best of all, probably work better than SSRIs and tricyclics, but we don't prescribe them because of the side effect profile and our fear of lawsuits. High potency benzodiazepines like, you know, Ativan, Xanax, they work. What's the relapse rate on the benzos? Any guess? 100%, close to 100% who are on a benzo, if they stop taking it, even with a very slow withdrawal, will relapse. It's like, I shouldn't say 100%, it's well over 90% relapse. So in terms of psychotherapy, really needs to be, you know, one of this kind of quote CBT components that, I don't know if I have a slide. It basically, I mean, this consensus statement came, I put it here because it came out in 1991. The research was done in the 80s that showed exposure-based treatments. How you do it, I think, depends on, the patient's willingness and ability to cooperate, as well as the therapist's skill. But it's basically getting people to face the things that they're afraid of and to tolerate it. So with part of the CBT package for panic disorder, maybe psychoeducation, sort of what I'm doing with you today, teaching them some, rebreathing or progressive muscle relaxation. But when I see patients, I tend to see people's treatment failures these days. And I would say that it's not just my experience, it's everyone who are experts. I would say 50% of treatment failures are not treatment failures. They were actually poorly treated. So when I always ask people when it came, did they teach you how to do progressive muscle relaxation? They'll say, well, they gave me a website or they gave me a book. Nobody can learn from a book. Nobody can learn from a website. You actually have to teach it to a person in the room, tape recorded. See how old I am, I say tape recorded, or give them a link to a website. So I have a link and it's on the Downstate website on progressive muscle relaxation. That's audio, but I won't give it to a patient unless I spend at least one session watching them and sort of coaching them and actually seeing that they can do it. And then when they come back, they did it, they got relaxed, and they come back next week and they didn't practice. We talk about why they didn't practice. The other thing, for example, that works very well, and sometimes that's a treatment in and of itself, is if you just have them purposely provoke panic. If you have a history of panic, it's relatively easy to do. As long as you're not hypertensive, you can just keep on hyperventilating, and within up to 2 minutes, people will have a full-blown panic attack. Stop, wait a moment, do it again and again. We do it 5 times in a row and then have them practice at home. It's easier said than done. I don't even tell patients in the first session that we'll have you hyperventilate as part of the treatment and experience panic, because they'll look at you and say, you crazy, and they won't come back. So it's one of the things. So And interpersonal psychotherapy is a modified form of dynamic treatment, which looks at themes of separation, conflict, anger management, and has actually been shown to be effective as well, but there's much less data on that. Does that answer the question? Any other questions in the chat?
Yes, there is a question asking for elaboration on a little bit more on interpersonal psychotherapy.
There is a book by Guilford Press. You can go online and read the description. I'll be happy to sell it to you. I'm not an expert on it. Actually, I did read the manual years ago, and here I'm being a little snide and sarcastic. I would say that it was a form of cognitive therapy, but just sloppily done, meaning it's more about, and the work is done in the relationship. Part of CBT may also be having people, track their anxiety every day, ask them to keep track of triggers when they have a panic attack, to write down what was the situation in the first column, what was the trigger, how did they feel? In the third column, you have to help them in the beginning, teach them to, what were the thoughts that went through their mind that made them scared. Usually it's something, as I said before, that they're afraid they're going to lose control, go crazy, die. And then once they're able to identify the negative thoughts, we teach them how to sort of accept the thought and counter it gently by saying, what's the evidence that I'm going to die? I've had 1 million panic attacks. Now, asking people, how many panic attacks have you had? They'll say 3 a day for years. And each time you still think you're going to die. How come? What's another way to look at it? And, it's basically what's the evidence? And even if the worst thing is going to happen, what's so bad about dying? And having a discussion about that, and getting people to sort of, quote, accept the symptoms and not fight them. I mean, people often think CBT means like forcing a patient to do something or educating them and pushing them. CBT is just psychotherapy with a specific focus. You can't be more motivated than the patient themselves. And this is from Gary Larson. It's an old slide. I love it. His controversial technique of simultaneously, confronting fear of heights, snakes, in the dark. In theory, if you did this, it would work. I mean, I've had patients who are very phobic, and sometimes bad stuff does happen. I had a patient once get locked in an elevator over a weekend and spent like 14 hours in the elevator. He didn't die. And actually it was a profound experience for him. He actually did much better afterwards. The worst had happened and he survived. Another patient who was terrified of losing his bowels, control. And then one day during the course of treatment, he probably had some sort of really bad bug and he actually did shit on himself. And as he told me, it was the most liberating experience in his life, because afterwards he realized it wasn't so terrible. I just want to cover quickly 1 or 2 other things and leave it open for questions. And I know you probably need a break. To the next person, I'm sorry I was late. I can blame downstate or the computer, not me. GAD is just excessive anxiety and worry for 6 months. And basically people have trouble controlling the worry, and they have 3 or more of these symptoms. If you can lay your hands on DSM-3 or DSM-3R and look at the GAD there, I like that definition better, only because they had like 24 possible symptoms. And people often have a hard time accepting that they're a worrier. They'll say things, what do you mean? If I don't worry, nobody in the family does. I have to worry. And when you kind of give them the symptom checklist and ask them to check off how many symptoms they have, and they check off 16 out of 20 or 16 out of 24, it actually helps people recognize what they're experiencing. They actually think, wait a minute, I know there's something I've forgotten to worry about. I have to worry. And the treatment, again, there's a high lifetime prevalence rate, women twice as men. GAD symptoms often start in childhood, pubescence, prepubescence even. It's the second most common psychiatric disorder after depression in primary care settings. The most common disorder we know is mixed anxiety depression, which doesn't even exist in DSM. What's the treatment? I'm being overly simplistic and we don't have enough time, but it's basically worry control treatment. Has like 2 phases. One is getting people to recognize that they're worried and that it's unproductive and it's not fun. And then basically learning to accept the thoughts and let it go and concentrate on doing something productive or fun. Anxiety management skills would be teaching slow breathing, relaxation, soothing yourself by saying this will pass. I've had it before. There's a role for dynamic and supportive therapy. GAD is actually very often comorbid. The results with the CBT treatment is much less impressive. The number used in the literature was 80 to 90% of patients with panic disorder will go into remission when you treat them with CBT. I can tell you that there's a study done from the NIMH that showed it was 80, 90%. That was when in the large studies, when you looked at 50 therapists, but if you actually the study was large enough to look at different therapists, there were some therapists who would have 100% success and some would only have 60 or 50%. So it averaged out to about 80. I don't promise 100% success. I don't want to lose my license. But if somebody is a relatively simple panic disorder, they all get better. GAD, they do get better, but they don't necessarily all go into remission. I think actually the only last thing we'll talk about is social anxiety disorder, which I think you kind of know is just the person is afraid of, there are two types. There's one that's, generalized, they're afraid of everything, so to speak, or sometimes it's just performance anxiety. Like some people with social anxiety disorder wouldn't be able to give a lecture in front of a large audience. Maybe they wouldn't be able to do it on Zoom either. Perhaps on Zoom they would find it easier. I wouldn't be surprised if some people with social anxiety disorder. I know the students are doing better. I mean, I've had patients who tell me when the pandemic started, they'll say, "Doc, you don't realize I've been training for this all my life. I kind of like being home and alone and not having to, to interact with other people because they're always worried that they're going to do something stupid and they avoid." And social anxiety disorder is actually really quite disabling and lots of dysfunction, and it really interferes with the quality of life. People with social anxiety disorder have a much higher rate of being single involuntarily. They don't really get married, or they get married and divorce. They don't really succeed as much as they could academically or in their job. But you have to recognize that the fear is excessive. And as I said before, there's a generalized performance type. The treatment, again, paradoxically, is, since it's an exposure, the best thing is actually group treatment for these patients. But the group needs to be a group that's specific, where everybody's socially phobic. When they join groups, they do really well, but many of them just avoid it, and they're really anxious when you try to put them in a group. They'll say, "You're crazy. That's what I'm afraid of."